So what I said was, go to port chamber view, switch on colors. There's a button of a colors, and once you switch on the colors, what you get a flow of a blood across the mitral flow. The red is towards the transducer, the blue is away from a transducer. Take a cursor, put it in this particular place, and then switch on a pulse wave Doppler spectrum pattern. So what you get out here is, you get over here is E wave, here is better clearly seen E wave, and this is the A wave. And look, this whenever we do a pulse wave Doppler spectrum pattern, this box is virtually empty majority of time. And other side, we see two lines in the sector, which is used for checking for pulse wave Doppler spectrum pattern. Then we switch on the sector from a pulse wave to a continuous wave Doppler spectrum pattern. And now we have got a continuous wave Doppler spectrum pattern. Look, the box is not empty. Why the box is not empty? Because it's measuring velocity across this whole line. And this is what we trace and call them as peak and mean velocity and the gradient. So I'm going to trace this Doppler spectrum pattern. This is, I'm tracing the mitral valve for peak and mean velocity and the gradients. So if you look at the screen, which is a little blurred maybe for you, what you'll see in the screen was, you see on the screen peak velocity, peak gradient, mean gradient, velocity time integral, and a heart rate. Heart rate is a little absurd because I have removed my arrow. Now look, my heart rate will come out correctly. It's not 192. This is little wrong as far as this word is evolution is concerned, but you can get the heart rate at the same time. So when we talk of a peak and mean gradient, whether it's mitral, aortic, tricuspid, pulmonic, we just trace the Doppler spectrum pattern to get the peak and mean velocity time integrals. Similarly, if I have to open up my aortic valve, here is my aortic valve. If I keep my cursor before the aortic valve, this is known as LVOT. If I move my cursor distant to the aortic valve, this is known as aortic valve problem. So whenever we talk of LVOT, this means before the aortic valve. After the valve is aortic valve leaflets. Similarly, we can keep a cursor in the tip of the tricuspid leaflets to look for tricuspid flow velocities. And here, if I'm using this, a pulse wave at LVOT, and same thing if I move distant to, look, almost the same velocity spectrum pattern would be there. Because whatever the blood which is going through aortic valve has to go through going through LVOT is going to the aortic. So that's how we look at this pulse and wave Doppler spectrum pattern, colors, and peak and mean velocity and gradients. Next comes mitral area by planning it. So we go to the same point, Plaque's window. In Plaque's window, we make parachute short axis view at aorta. Rotate, go to papillary muscles, and gradually come back towards mitral valve. And wherever you start seeing a mitral valve, that is mitral valve area in 2 dimensions. So now you can see a zoom view of 2 dimensions area. This is an area, and this is the zoom view. We just trace from inner border to inner border. It's almost 4.5 centimeters square. Then same places like we measure my LVOT. Many books will say many things, but where have to measure the LVOT is at the hinge point of aortic valve leaflets. So if this is a hinge point of the aortic valve leaflets, this is one over here, this is the hinge point of aortic valve leaflets. So these are the aortic valves, right coronary cusp, non-coronary cusp. The hinge point of right and non-coronary cusp, we get the LVOT diameter. So I'll go back again and I'll try to zoom up my picture for the same. Hinge point over here. And it's a mid system. Then we have to measure my LA. And how do I measure my LA is go to the end of systole, measure your LA into dimensions, divide by body surface area. 31 divided by body surface area. Similarly, if I have to measure my LV cavity, how I'm going to measure my LV cavity is I'll go to the end systole or end diastole or beginning of systole and then I'll look my end diastolic LV dimensions. 43 divided by body surface area. Similarly, if I have to measure this, I'll have to end systole. So this is my end systole dimensions. That was 43 and this has got almost reduced to 30. So this is end systolic and diastolic dimensions. Now, where to look for my pulmonic blood flow samples? 4-chamber is good for mitral. 5-chamber is good for aortic. Another focused RBRA view is good for tricuspid valve. Rotate to 3-chamber view, we'll get again aorta and mitral valve. But where do we get pulmonic? You go to Plaque's window, parasonic short axis view at aorta, rotate clockwise to get a pulmonic artery seen over here. Look, this is very important to look at a pulmonic artery, and here is a pulmonic arterial flow. This is normal, 0.81. The normal velocity of pulmonic flow is half of aortic. Aortic is 1.7, so half of aortic is pulmonic. Half of mitral, which is 1.3, is tricuspid. So this is how we look for a color Doppler as well as the measurements. Now, one of the most important measurement which everybody wants to understand is ejection fraction. So let me show you how do we look at ejection fractions. So we'll acquire 4-chamber view. Keep it with you. Then acquire 2-chamber views. Keep it with you. Or I can go to 2 images simultaneously. First 4-chamber and second is 2-chamber. Now I can do the measurements. First I'll do my measurement with 4-chamber. So I'll go to measure, go to volumes, go to biplane. So first is asking you end diastolic volume. So I'm starting with one annulus, that's a medial annulus. Trace the border of the endocardium all the way up to apex. Bring it back and then adjust with your apex. So this is end diastolic volume for 4-chamber view. Then systolic volume, scroll the probe and then you get another cursor. Then you calculate the end systolic volume. So what we get? Ejection fraction of 52%. Now we keep it this in mind. Now I'm going to go to 2-chamber view. Do my 2-chamber end diastolic volumes. And systolic volumes. So now look at your biplane ejection fraction. is 59.85%. And that is how we always look at biplane modified Simpsons. Why do we call them modified? Look, this is all divided into diskettes. And machine calculates individual diskettes area, volume, area into height, individual volume, and then clubs it, just summate it to give you endoscopic and systolic. And this is biplane modified Simpson is the most important method in two-dimensional psychophysiology. You talk about ejection fractions. Now I'll take up questions one by one because that will solve so many queries in everybody's mind. So I wanted to show a Doppler. Then what is pulse wave Doppler? What is continuous wave Doppler? And how to do basic measurements? You can raise your hand so that I can answer you one by one. Dr. Veena Bang, unmute
Hello, sir.
yourself.
Yes, hello, sir.
Go ahead.
Can you please tell us how to look for pulmonic artery again?
Pulmonic artery. All right. Can you lower your hand, Veena? Pulmonic artery visualization is we go to Plaque's window. Show the camera. Look at the camera. Look at the Plaque's window. Is Plaque's window is clear? Rotate camera to 90 degree. Sorry, transducer to 90 degree. And it should be at the level of aorta. Now, can you see the pulmonic artery? The pulmonic artery is right over here. And this pulmonic artery is bifurcated. Look, the blood is going into two different directions. One is right and second is left pulmonic artery.
Yes.
So, step is Plaque's window, rotate 90 degree. This is mitral valve 90 degree. There's slight footprints towards aorta. The aorta opens up and the pulmonic artery peeps out in left hand side.
Sir, on the left side, there is tricuspid valve, right? On this side?
This side is tricuspid.
Yeah. Okay, sir. Thank you, sir.
Okay. Then we go to Dr. Mull. Dr. Mull, you can lower your hand and ask the question.
Okay. I wish you a very good evening, sir.
Thank you. Dr. Mull.
So I have a couple of questions actually. The first of which is at the time of taking the dimensions of the left ventricular cavity, what surface marking do we, what marking onto the image do we keep as reference? Just how you told that it should be the rim in case of the, LV outflow tract or the aorta. So for the LV, where exactly should it be? That's the first question. And the second question is...
I'll just take a second question later on. Look at my Plaque's window.
Sure, sir.
So measurements are always in the beginning of URS complex. Look at the cursor. The cursor is right over here. So this is endostelic LV cavity, correct? So it should be basal in posterior wall and basal anterior side. 44 divided body surface area will give you absolute value of LV. Correct? Are you there or lost your connection?
Yes, sir. So where exactly like the basal anterior septum?
Yeah, this is endocardial.
Sir.
This is myocardial.
Sir.
This is pericardial.
Yes, sir.
So let me just take out this and where to keep it is like look at your immediate quality. This is where you keep it. The posterior wall over here, inlet, and here is the basal anterior side.
Okay.
Okay.
Is it just in the same plane where the where the mitral valve completely opens? So it has to be just in the same plane, right?
Almost, yes. Mitral valve opening happens in almost the mid segment. Look, mitral valve opening is happening in the mid segment, but we are looking at the basal segments.
Okay.
Next question.
The next question is in modern day echocardiography, what is the role of M mode measurements? Like, do we stick to 2D measurements itself, or for the ejection fraction or for the LV cavity dimensions?
First of all, forget about ejection fraction.
Sir.
Never use ejection fraction as a calculator for LV function. Look, if you are a very good echocardiographer, we make our work easy. I've drawn a line right into the center of the sector. Correct.
Sure.
Then 90-degree angle added in M mode. Now
Yes,
my M mode is cutting across aortic valve. So what I can do is I straightway go for aorta measurement,
yes,
LA measurements, and AV cuff separation.
yes,
So it'll give me index value of LA 32.54 divided by body surface area. So it gives you index value at the time. Second important thing is you just move your cursor to just to the tip of the mitral. If you move your cursor distant to mitral left tips, you don't have to exert not many things. Straightway go to LV, interventricular septum,
yes, sir.
posterior wall. In between, we could see this left ventricular dimension during diastole. Then systolic dimensions, systolic, and this is systolic. So everything is right in front of me in one minute.
Yes, sir.
This is how we utilize M mode in clinical practice. But the most important utilization of M mode is, look, this is, we cut a M mode across this annulus. This is more like mitral annular plane systolic expression.
Okay.
Same thing if you move to tricuspid annulus. This is tricuspid annulus plane systolic expression. Otherwise, M mode has got a very small utility as of today in clinical practice.
Okay.
Okay.
Okay, sir. So we do not like while measuring the dimensions, we will stick to the 2D image itself, right, sir? In terms
Perfect.
of the dimensions,
That'll be perfect.
not M mode at all.
No, not.
Okay, sir. Okay, okay.
Dr. Jyoti, lower your hand and ask a question. It's not Dr. Jyoti, it's Dr. Sharmina,
So,
roll number
sir,
5 online. Go ahead, Sharmina.
good evening, sir.
Good evening.
Sir, I have two questions. Sir, if there is ventricular septal defect, then how we can measure LV function by Simpson method?
We do the same thing as we do without VSD. Only fact is your ejection fraction may be variable because you have got two outlets. But measurements remains the same.
Sir, I can't understand clearly, sir. So two outlet means
LV outflow and VSD outflow. You'll find two outflows, but measurement pattern will remain same. It will not change. We'll go the same 4-chamber view to do the measurements for ejection fraction. Okay.
okay, sir.
Any other question?
Sir, same question. Sir, from first class, we know about leading edge and trailing edge. Sir, can you repeat it in this class again by measurement?
Whenever we do M mode measurements, we use leading edge to leading edge. Whenever we do 2 dimensions measurements, we use trailing edge to leading edge. Look, if I'm doing 2 dimensions view, this is a trailing edge of this image to leading edge of this image, correct?
Yes.
If I'm doing an M mode, so I'll be measuring from leading edge to leading edge. So I'm going to measure from leading edge to leading edge. Although this concept should go away completely as far as I understand now. Look, if I'm measuring this patient from aorta to first begin, this is leading edge to leading edge.
Okay, sir.
Then this is leading edge to leading edge. And then this is leading edge to leading edge aortic. But it's hardly a millimeters difference, not more than that.
Okay, sir.
All right.
Okay, sir. Thank you, sir.
Tajinder Kaur, lower your hand and go ahead.
Good evening, sir.
Good evening.
Sir, what is the preferred mode of measurement, right? We do by 2D echo or by M mode in daily practice?
What measurement?
LV measurement, sir. And
Always.
other measurements also.
We try to do always in 2 dimensions.
Okay, sir. And my second question is, sir, kindly repeat how to calculate peak and mean gradient.
All right. Look at the screen. This is what the Doppler flow pattern is. Correct? This is a Doppler flow pattern across mitral valve. So I'll go to mitral valve trace. Now take this Doppler spectrum pattern. Start with the beginning of this Doppler spectrum pattern. Go up. Come back. Go up. Come back. This. Now you get a correct heart rate. So once you trace this Doppler spectrum pattern, you will automatically get peak and mean velocity gradients and velocity timing T. All right.
Okay,
Dr.
sir.
Muzaffar Beg, Muzaffar Ahmed.
Good evening, sir.
Good evening.
While going through the color Doppler across the mitral valve, you mentioned, sir, we two methods. One is a pulse wave Doppler, and the second was the continuous Doppler.
Correct.
Yes, sir. When do we use pulse wave? When
Normal circumstances, we always use pulse wave Doppler.
okay,
Whenever this stenotic lesion is there, as you see in the screen, look, my Doppler spectrum pattern is easily measurable. Correct? If I can't measure my Doppler spectrum pattern, even by reducing my baseline down like this, if the spectrum is still high, then what I use? I use a continuous wave Doppler. Always, whenever there is obstruction of valves, we
Okay.
always use a continuous wave Doppler. Or whenever we look for a regurgitant velocity, like MR jet velocity, TR jet velocity, we always look continuous wave Doppler.
continuous wave Doppler. What about, sir, across the aortic valve?
Across the aortic valve is same. If you are looking at LVOT, pulse wave Doppler. If you are looking at aortic valve, which is stenosis, then we look at continuous wave Doppler.
Thank you, sir.
Dr. Deepak.
Good evening, sir.
Good
Sir,
evening.
LV mass measurement and this thing, sir. How to measure LV mass in plaque view.
Look, this is how we measure LV mass in plaques. This is what is recommended in 2 dimensions LV mass resolution.
In in end diastolic or
I'm going to show you.
yeah,
Go
yes, sir. Thank
short, rotate 90 degree. Now you can see my image. Parasemic short axis viewer type papillary muscles.
yes, sir.
Correct. Draw a line right
Yes.
into the center. And take an M mode. Please go to LV measurements. This is septum. This is other part of a septum. This is left ventricular internal dimensions. This is posterior wall. Then we go to systole, septum, left ventricular internal dimension during systole, and then the posterior wall during systole. Now look at the screen on left hand side. LV mass 167 grams. RWT.
Okay, sir.
This is how you should remember how to calculate LV mass by 2 dimensions echocardiography. 3 dimensions is different.
Okay, sir. Okay, fine. Thank you, sir.
Dr. Mahua,
Good evening, sir. I have 2 questions. First one is where to measure the LA, specific point where I can get the LA measurement in 2D. Every time I feel I am getting a dilated LA without any reason.
the best part what your question answer would be, you look at my screen. In screen, what you can see is, you see a sector. In this sector, draw a line right into the sector of the screen. Correct?
Yes.
What exactly happens? Now the aortic valve is right into the center of the screen. Correct? This is the aortic valve, which is right into the central screw. This is the aortic valve. And now, this is where you should measure, sorry. This is where you should measure your LA size. 33. Not convinced, not happy. Because you don't make this view like this. What you are fond of making a view like this. Correct? Your views like this or not?
Yes, sir, mostly.
99.9%. We are one space down. We have to come one space up. And whenever we will come one space up, this is what the view which is recommended. And that's why she is measuring 3 different dimensions in a same patient. And second thing is LV dimension is during and systole. So now this is my LA dimensions. 29 millimeters divided by body surface. Whenever you see both the anterior part of LA clearly seen and the posterior part of LA is clearly seen, that's where the dimension is. Any other
At the
question?
level of, sir, at the level of aortic valve or at the level of sinus? It is above the aortic valve, isn't it, sir?
Look, this is what is where the aortic valve is now. I'm talking of at the level of diastole, not in systole.
Okay.
Now, if I save this image, I'll remove this image because removal becomes mandatory. Otherwise, machine starts cloning by itself. If you look carefully, this is the hinge point of AML.
Yes.
This is the hinge point of PML. So LA should be in the body from this point to this point.
Okay, sir. Sir, I have another question. As I am a pediatric cardiologist, I need LA aortic ratio sometime, mostly in the case of
LA
TT.
aortic
LA
ratio.
aortic ratio.
Very simple. LA size you measure in diastole.
Yes,
Aortic
sir.
size you measure in systole.
So is in my machine, there is if I need LA aortic ratio, I have to do it in the M mode. So should
You
I
can do
call?
in M mode. You can do in M mode also.
So 2D, my machine is not giving. So should I call my vendor
When you
to
can
fix
call
it?
your vendor also to fix it. Or else what I showed you earlier, if you go to this picture like this, when the aorta is in the middle, I'm cutting the aorta into the middle. Now this is what is trying to make the best possible view. Now aorta is cutting into the middle. And when you perfect cut, this is aorta and this is LA. Correct? So now you got aorta LA ratio almost 1:1.
Yes, sir.
That's how you can do it. In pediatric population, the images are very clearly seen.
Yes, sir. So is it correct to do it in if I need LA aortic ratio to?
Yeah, 100%. This is
M
what
mode.
you can do in this mode. Because what exactly has happened, what you have measured is you have measured during systole the aorta and diastole is the LA.
Okay, sir. So I am doing this one. So is it correct till now?
Correct.
No?
Correct.
Okay. Okay, sir. Thank you, sir.
Dr. Pote, Prajakta Pote.
Good evening, sir.
Good evening, Prajakta.
Sir, I want to ask, whenever we are putting a pulse wave Doppler gate and in 4-chamber view, so where should be the gate exactly at the, it should be at the mitral valve leaflets or at the base of the mitral
At
valve?
the mitral valve leaflet tips, aortic valve leaflet tips, tricuspid valve leaflet tips.
Okay, okay, sir. Okay, sir.
Dr. Ashish.
Sir,
Yeah.
please illustrate me how to take the pulmonary pressure and at what point the pulmonary pressure should be taken.
You are talking of pulmonary artery pressure?
Yes,
Is that
sir.
right? Okay. So we take a pulmonary artery pressure, we go to focus RBRM view and focus on tricuspid valve. Once I focus on tricuspid valve, switch on the colors. Now you see a blue color of a TR jet.
Okay.
This is the blue color of TR jet.
Right.
This one.
Okay.
Correct?
Okay.
So I'm going to put my cursor right into the neck of this TR jet.
Okay.
That's what I'm going to do is, I'm going to keep my cursor into the neck of this TR jet. So I'll be keeping my cursor in the neck of a TR jet. Correct?
Yes, sir.
And then I'll wait for the Doppler spectral flow to appear, switch on continuous wave Doppler, and see how much is the gradient across this TR jet. I'll try to show you better because intermediate is coming. First step, colors. Identify the where leakage point is. Keep your cursor right into the neck of this. Switch on continuous wave Doppler. Now you got a beautiful Doppler spectrum. So this is what the TR jet 2.37 20. You add RA to it by IVC. I'll just show you IVC. See the later? Good name. So I'm rotating counterclockwise and now I can see my IVC. My IVC measurement is at always at the distal of the hepatic vein RA IVC junction. So this is hepatic vein. This is IVC junction. This is RA.
Sorry.
I'm going to measure my hepatic IVC at over here, which is almost 8 millimeters.
Right.
Any IVC less than 13 millimeters is considered as volume deficit. So you look at an IVC side. In this patient, we take RA pressure is 0. Otherwise, his TR jet gradient is only 25 or 27, whatever it is. Just a second. You can see that gradient again. Like 22 millimeters of mercury. His RA pressure is 0. So we talk it 22.6 into 22 is 13.2 plus 2.1 would be the mean pulmonary artery pressure. 14.3 is the mean pulmonary artery pressure.
Okay. Can't we take measurement at that plaques video where we can visualize the pulmonary artery?
If you really, no, tricuspid velocity, not pulmonic artery. We are looking at tricuspid velocity.
Yes. Thank you. Thank you, sir.
Pressures. Dr. Mal,
So, if I may ask you, why do we prefer 2D measurements over M mode, sir, with respect to the LV?
good questions. Answer to this question is now look at this image, correct? That's what you always try to make in your clinical practice because this looks so beautiful. If I do my M mode now, so if I'm doing an M mode of LV, look where I'm cutting my M mode of LV. One part I'm cutting at the basal posterior wall, and this is mid posterior wall. Although I should cut it basal anterior side.
Yes, sir.
So I'm not doing a correct measurements. So let's measure how much it is. This is 56. If his body surface area is 2, is 28. Correct? Now let me go to see a correct measurement, which is not at the mid segment. This is from this point to this point. 44. So his LV measurement is 22 millimeter. That 56 gives you an alarming value because that anything about 656 is considered as dilated. But
Yes.
his true measurement is not the 156, is only 45 millimeters. Since we are almost measuring from basal interseptum to basal posterior wall, and when we are doing M mode, it was like this. Correct? We can improve this. if you are a really good echocardiographer, if you have a good practice on echocardiography is, as I said, bring your cursor right into the center, aortic valve, draw a line right into the center. Correct? Do an M-mode. So you get aorta, LA, cuff circulation easy. Move your cursor distal the tip of the leaflets. And you get what was 46. It should be the same, 47. But here I'm cutting. Where I'm cutting? I'm cutting over here is basal interseptum and basal posterior. And this will only be possible in 60% of the population when my cursor is like this. 90 degrees.
Yes, sir.
All right. It'll run with experience. Don't worry about it. You're too slow to begin with.
Yes, sir.
Dr. Charlene, go ahead.
Sir, is it possible to measure LA pressure from echo?
LA pressure from echo. Why not? Last function evaluation is LA pressure.
How can we measure?
Wait for time. We are starting a journey of echocardiography. We are on the foothills of echocardiography journey. LA pressure measurement is, we look at a mitral Doppler spectral flow. We look at E2 prime septal, E prime lateral, LA volume index, and TRZ velocity. 5 of these spectral patterns helps you in assessing LA pressures. Topic will come automatically. Wait for some time.
Sorry, sir, there was another question from my end. It was regarding, sorry, sorry, I forgot it. Just as I'll get back to you.
Alzheimer.
Sir, actually, I can't understand how to measure LA pressure. Sorry, sir. Please describe it again. Or
Sharmina, you have to pay one more extra fee. So what we do measure is, we look at mitral flow first. So this is first parameter, E wave and A wave. So I'm
Yes,
going
sir.
to store it, 80 and 71. Then second parameter is, I'm going to go tissue Doppler imaging, take my E prime septal. So I'm going to take my E prime septal, machine has already taken it. Then I'm going to take my E prime lateral. Machine will take it automatically. And now machine has not shown me EA ratio. So I'll have to go back and measure my EA ratio. Now look at everything seen on the screen. EA ratio, E wave, A wave, E prime septum, E prime lateral, and average is 5.79. Any value less than 10 is considered as normal LA pressures, that is 10 or 12 millimeters of mercury. To add further to it, we go and measure the productivity. To add it further, we go and measure the LA volume index. So I'm going to measure the LA volume index in 4-chamber and 2-chamber view. So this is 2-chamber view. And then I'll move on to 2-chamber. That is 4 and this is 2-chamber view. So I'm going to measure in 4 and 2-chamber view. Now maximum LA size and DASI. So I'm going to go to generic, I'm going to go to volume, then I go to LA volumes. So I'm going to measure my LA volumes. One LA volume, second LA volume, This is two areas, one area, second area. Then either of this, if this is shorter or this is shorter length, this appear to be shorter. And once I draw this, if you can see on a screen, 44 ml is the absolute value of LA volumes. Divide by body surface area is 2 is 22. That's fourth parameter. And then we take a TRZ gradient. That's what we put TRZ gradient as 2.37. So if my E2 prime average is more than 10, LA volume index is more than 34, TRZ velocity more than 2.75 meters per second, then we consider my LA pressures are elevated. That is approximately 15 millimeters of mercury. If my E2 prime average ratio is less than 10, LA volume less than 34, TRZ velocity less than 2.75, my LA pressures are almost normal, 10 to 12 millimeters of mercury.
Okay, sir.
Shamina, okay?
Oh, okay.
Little
Okay, sir.
cumbersome process, but you have to do it every day.
Oh,
Dr.
yes.
Madhav Bansal, unmute Madhav.
So regarding LV measurement, what I see is the central part, the body of the LV is wider. Where we are measuring the LV is at the tip of the mitral valve, LV dimension.
Correct.
So
So,
should we
correct.
wide
I'll give you an answer for this very simple. Where do we dilate when we grow?
at the center actually, sir.
Tummy.
Tummy, yes, sir.
So normal cases, the LV will not be dilated in the mid segments. Whenever the LV dilates, it always dilates in the mid segments. So what we do is, we are not dependent on LV in the mid segment. We are dependent on LV in the basal segments. Because the base is there, apex is fixed. The base moves through the apex. So we always do a measurement at the level of bases.
Okay. Okay, sir. Thank you. Thank you, sir.
Dr. Mal?
Yes, sir. So actually, while mentioning all these measurements of the LV, we are indexing it with the body surface area.
Correct.
So the values which are listed onto the screen, do we have to correct them with respect to the body surface area?
I'm sorry, what I did was, I did not feed his body surface area, height and weight. Let me feed height and weight in front of you. His height is 160, weight is 60, his body surface area is 1.62, correct? Now, let me measure his LA size. This is what I do always in my practice. If I've got a good images, I don't spend time calculating two-dimensional set. So I'm going to measure his LV. So look, what we measured there was 27, sorry, 45. So in this method, we are 48, and now we have got index value of 30 millimeter per meter body surface. So machine has already calculated it for you. Correct? Same thing, if I have to go and measure my LA, I'm going to measure my LA now again with the index value fed into the system. Now look, my LA is 21. 32 is LV, 22 is LA. So measurements are good. So just feed height and weight, you get index value automatically. Index has got more important than absolute value.
Correct. So all the reference values which we have to compare it with the index value itself, right?
Always, because suppose my body surface area is 2.4.
Correct, sir.
And my LV dimension is 60. Even that 60 will not be considered as bigger for my 2.4. body surface area. If the same LV dimension of 60 is given for 1.7 body surface area, so that be dilated.
Okay. Yes, sir.
Dr. Muzaffar Ahmed?
Yes, sir. Do we do the Doppler studies in the PLAX view? If you know, then why?
No, we do not do in plaques view because we are perpendicular in plaques. The principle of echocardiography, imaging in perpendicular to get the best views. Doppler always parallel. Look, I showed you a parallel long axis view where I did not see any Doppler measurements. When I made it parallel short axis view at aorta, I could measure my pulmonic artery measurements.
Okay, thank you, sir.
Dr. Chandrakant?
Hi, good evening, sir.
Good evening. Good evening,
Sir,
Chandrakant.
I want to know once again, sir, pulmonary artery pressure, how to measure.
Okay. So this is pulmonic artery pressure measurement is. We go to focused RVRA view in 4-chamber view. Look at the TR jet. Put your pulsate Doppler spectrum pattern in the TR jet or in the neck of a tricuspid regurgitation jet. Then switch on a continuous wave Doppler. You get a Doppler spectrum pattern like this. Measure the peak velocity, which is 2.37 meters per second, giving a gradient of 22. Now, this gradient is given from RV to RA. RA has its own pressure, which is determined by IVC. In this subject, IVC was small in size, so RA pressures are 0. Normal IVC is 20, collapsing more than 50%, RA pressure 5. If it's dilated, does not collapse, RA pressure is 15. And if it's in between, that is 10. So this is small IVC. So 24 into 0.6, that is 13.2. Add 2.1, 15.3 is the mean pulmonary artery pressures. Any pressure more than 20 millimeters of mercury is considered as elevated. Mean pressure. We are not talking of peak pressures. All right. Madhav Bansal.
Sir, this regarding this IVC, please repeat how much is IVC, how much we have to take that pressure, that 5, 10, 15, that thing.
Okay, सीधा लिख जाओ.
हाँ सर, कल नहीं वापस कल रहे. ओके सर, ओके.
आप लोगों को अपने मोबाइल को थोड़ा सा ऑफ, स्पीकर को ऑफ कर दो.
फोन ಕೇಳಿ ಕಾಲ್ ಮಾಡ್ತೀನಿ.
अब कोई बोल रहा है, देखो आप सबको डिस्टर्ब कर रहा है वो. प्रैक्टिस करो, जरूरी है, लेकिन प्रैक्टिस स्विच ऑफ करके करो. मोबाइल मतलब माइक को साइलेंट करो. चलिए. Now look, we can't see his IVC. Very small, it is further collapsed. Okay.
Yes, sir.
Now can we see the IVC? So this is hepatic vein, this is IVC, this is hepatic vein IVC junction. Just distant to take is, this is the size, it's 7 millimeters. Okay, I'll store it. Now I'll move to end expiration. It's almost disappeared. End expiration. So with inspiration, it disappears. So normal size is 21. If it reduces by 50% with inspiration, my RA pressures are 5 millimeters a month. If it's 50, it reduces less than 50%, then RA pressure is 10. Normal size, more than 50%, 5. Normal size, less than 50%, 10. Then you go to higher side, IVC size more than 21 millimeters of size. If it collapses more than 50%, RA pressure is 10. And if it collapses less than 50%, then its RA pressure is 15.
Okay, sir.
Some people take this pressure 5, 10, and 15 as 3, 8, and 12.
3, 8, and
12.
12. Okay.
Instead of adding 5, 10, 15, some people add 3, 8, and 12.
Okay.
All right.
Okay, sir. Yes, sir. Sir, one more.
Go ahead. Quickly go ahead.
Sir, In a few cases, I found that in the plex view, I got a trace AR, aortic regurgitation, but I could not find it in four-chamber view.
In fact, whenever we are going to quantify AR, one of the best methods for looking of a quantification of AR is in plaques window only, where we look at a vena contractor, the jet through which the jet which is originating between two leaflets of the aortic valves. But why that is not seen in another 3-chamber or 5-chamber view is because in a plaques window, the jet is seen between right coronary cuspid and non-coronary cuspid.
Okay.
So next time, if you happen to feel a problem that you can't see in 3-chamber or 5-chamber view, is just angulate your probe. You'll find a AR jet. It all depends from where is originating. If you are having a right coronary cusp and non-coronary cusp, you may see in 3-chamber or 5-chamber view. But if you angulate, then you start seeing again if you're not able to see it.
Okay, sir. Okay, sir. Thank you. Thank you, sir.
Right. Dr. Shushma, if I'm correct, roll number 13.
Yes, sir. Yes, sir. Good evening, sir.
Good
Sir,
evening.
two questions. One is, how do we get focused RARV? Because every time you're saying when we want to measure TR, we want focused RARV.
No, I've been waiting
And
for this question for last 15 minutes.
okay. And second question is MV planimetry, you said. So it is to be calculated at the papillary muscle, or you are saying at the valve level, you are saying?
No, at the tip of the valve level. From papillary, I'll just show you both the things together. Boom, camera. Look, this is our 4-chamber view, correct? My apex is in the sector. This apex is right into the sector. Now look at my hand movement. I'm going a space up. My apex has gone away. And this is RVRA focused. Clear?
One intercostal space above.
5th to 4th.
Okay. Okay. And
Right?
orientation marker is in the same direction.
Same. I'll just show you a difference between these two because we are just beginning our classes. Look, I can't see a good TR jet in my R4 chamber view. Correct. As soon as I start getting the focus RV view, I'll start getting a good TR jet. Now you can see a TR jet neck gradually. Now you can see a better TR jet.
Yes.
Which was not seen in 4-chamber view.
Okay.
Second, your question was, I said go to papillary muscles level, then gradually come towards aorta. So in between, what you will find, the mitral valve leaflet tips.
Yes.
Correct. Why this? The answer lies from this 4-chamber view. If I go to my 4-chamber view, in papillary muscle where I'm cutting at this level. I'm cutting at this level in papillary muscles, correct?
Okay, correct.
Cutting at this level in the papillary muscles. When I'm going from this level to aorta, so what I'm cutting across first? I'm cutting at the tip of the mitral valve. Here.
Okay.
From here, I'm going to tip of the mitral valve. And then I go to aorta. So as soon as I saw tip of the mitral valve leaflets, that's where we should do a planning.
Okay.
Right?
Okay.
All right. Dr. Shantanu P. Mal again.
In certain subset of people like really obese individuals or in cases of COPD, the window is poor when it comes to like these views. So at those times we have to go for the subcostal and take measurements. So like will we discuss?
We don't take measurements.
We don't
take measurements.
Okay. So subcostal measurements are not considered standard.
No.
Okay, sir. Okay, thank you.
This is Priya.
Good evening, sir.
Yeah, good evening, Priya.
Sir, I just wanted to know, LA index volume cutoff is 22 and LA index cutoff is 22, but LA volume cutoff is 33. While measuring, when index coming more than 22, but LA volume coming in normal, like less than 33. So what we consider, sir? Which one is right, sir?
When you're doing LA measurement AP diameter, which is less than 22, is considered as normal, but you find LA in measurement more than 22, LA volume is less. It means
Yes,
your
sir.
measurement of both the things could be variable. The
Yes,
AP
sir.
diameters could be variable or your LA volumes could be variable.
Okay.
Second important thing is, look, LA dimensions and LA volumes are two different things. LA volume is dependent on dynamic conditions like
Okay, sir.
volumes. Suppose you are dehydrated, your volume is less, you may find less amount of LA volume to be there. So what exactly happens if you're of physicians when we treat people for heart failure with preserved ejection fractions? So what do? If we see LA volume which is high, we give them ACE inhibitor or ARBs to reduce their LA pressures. What do you mean by? We reduce the preload. So today my LA volumes may be high, but once I give a preload, my LA volume becomes normal. But if they are for long time, which leads to dilated of LA size, the LA size does not revert back immediately. So you may find a dilated LA size in AP diameter, but your LA volume may reduce. That you have to check whether the patient is any on medicine or not.
Okay, sir.
All right, Priya, anybody else? Final questions? I know a lot of things are there in your mind. The more you'll ask, the more you'll get confused all the times. But it's better to be confused rather than not knowing anything. All right. I hope we had a good, successful session, and we'll stop it over here. And next week, get ready for examination on Wednesday night. We'll have an examination from 9 o'clock till 10. And then 10:30, we'll have a review examinations. So whatever you did, everything will be told to you by yourself only. You don't have to go anywhere else. Just check your exam result then and there. And then we'll review the examination at 10:30 in the night so that you understand what is wrong, what is right from your point of view. With this few words, let me say thank you, good night, stay safe, and we'll see you next week. If everything goes well from a Pakistan and India side, we'll be there next week together on the same platform.